I'm really excited to be here, really excited to be speaking to such a large audience of people. Not done that for quite a long time with COVID and everything else which has been going on. But also this topic is something which I'm really quite passionate about because pediatrics is something which I find really interesting. I do lots of different jobs. So I work in the MRI, Adult Major Trauma Centre. I also work at the Children's Hospital in Manchester, the Royal Manchester Children's Hospital, have done for many years, even used to work at Booth Hall for those people who might even remember that. And I now do a bit of pre-hospital care as well with the air ambulance here and with basics. And one of the things we've found over the years is that if you ask any clinician who works in the sort of areas that we do, what are the cases which sort of stick in the mind and perhaps give us a little bit of anxiety? It's commonly pediatrics, and it's pediatrics and airway and major trauma and stuff like that, pregnancy and emergency. So there's a classic group of these ones which always give us a bit of anxiety. And I think that's kind of interesting because if you think about it, there's a lot of skills that we have from adult medicine, which we generally are more familiar with, which we can use in pediatrics. But that's not the message that a lot of people will tell you. A lot of the messaging that goes around pediatrics is it's so different, it's so bizarre, so you can't do this, it's really complicated, it's a completely different system. And I'm going to try and challenge that today and see if we can make this a little bit more comfortable and try and assure you or reassure you that actually there's a huge amount of things that you can do and we want to see you do. So when you're bringing a kid into RMCH or your local trauma center or trauma unit, that there's actually a lot of things that you would do with the kids that you would ordinarily do with the adults as well. That's going to be the big message. So I've got a question for you as well. I like to start with an early question, just as Andy does. And here is the question. I want you to tell me, if this button works, how scary are kids? I don't know, put a number from 1 to 10. How scary do you think kids are in the context of trauma? So yeah, just chuck a couple of numbers at me if you can in the web chat. 9, 8. Yeah, well, this is what I said, isn't it? 7, 8. Right? Okay. All right. Okay, that's probably enough. I think that proves my point, doesn't it? That most of these numbers are towards the high end that people are quite worried about. And I kind of want kids 0. Edward, Elswood, good man. Well done. 407 is also a good number. We'll leave that to one side. The thing is, though, that this is the message which has been promulgated for many, many years. Now, this was originally a phrase which was put in APLS, the Advanced Paediatric Life Support Manual, put this front and center in its very first edition. And I know the guy who wrote it. And I also know that the guy who wrote it regrets putting it into the manual because it's kind of true, but it's kind of not true. It's kind of true because kids are not just little adults in many ways to talk about. But the way that that's been perceived is that unless you're a super duper expert and you see lots and lots of pediatric trauma, you're not capable of doing it. And that's not true. In fact, pediatric trauma is incredibly rare. RMCH, which is where I work, is arguably, and I think the numbers back this up, the busiest pediatric major trauma center in the UK. And the sort of numbers you're looking at are in the low hundreds per year. So it's not like adult medicine. It's not got the same volume. And there are very, very few people out there who truly spend all of their time doing major trauma in kids. It's rare for everybody. And that's really important, that you may feel that you've not got a huge amount of experience in this. But that's the same for everybody. Even working in a major trauma center like I do, I don't see a lot of really seriously injured kids. It takes a long time to get that kind of experience, but we still have to treat them. So what can we do? And, fundamentally, if I want to push the thing one more time, kids are not little adults. Well, if you can find one that grows into a hippopotamus or something else like that, I will give you a prize. To my knowledge, so far, all the little children have grown into large adults. That's what they do, and pretty much never seen that happen before. So the question I've got as we're going along is, can we actually treat children as if they are small adults? Again, people have been telling you they can't. I'm going to try and present to you that you can. So let's think about an approach. And the way that this talk is going to work over the next 30 minutes or so, 40 minutes, is we're going to take a wander through some concepts. Then we're going to take a wander through some diagnostic type something about how actually we approach children. What can we do in them that we can take from the adult world? And then we'll talk a little bit about the differences and how the injury patterns are different. And then we'll talk about a little bit about what we can do to be better and more comfortable about how we treat the kids. So that's kind of the ethos. So your approach to any major trauma type patient, really spinal protection, ABCDE, that's the one that we kind of get taught. It's okay. It tends to give people the idea that what we're doing is a process rather than an outcome. And what I mean by that is when we see trauma teams work and say, you're an airway, you're on breathing, you're a circulation, you're seeing disability, or when you see small teams, they work through this in a sort of longitudinal manner, but it doesn't actually address what we're doing at each of those phases. And one of the things that we take out of the attack course, which I've done quite a lot of work with over the last few years, is to take a slightly different approach in trauma from the ABCD approach, which is what we tend to teach, and do something around what we call March. Now, at first glance, it kind of looks similar, but it's not quite the same. So the March approach for major trauma is, deal with massive hemorrhage initially. A massive hemorrhage in children, you've got to remember, could actually be really quite small volumes of blood. 50 mils coming out of a 6-month-old is a significant bleed out of that child. Looking at the airway, is it okay? Things are okay. I'm not going to repeat all the things that you know about how to assess an airway. That's part of what we do. There will be variation in terms of the equipment that we use and the size. We'll talk about that in a second. But it's the same principles. The children still need an airway, just like adults do. Respiration, the ventilation, the breathing side of things, it's more than just whether the patient's breathing, but the power of the respiration, whether they're actually shifting gas, and how we assess the chest. And again, there's some differences in the children, but you're still going to do the same approach. You're going to look, you're going to feel the chest, you're going to feel for things like surgical emphysema, you'll feel for things like rib fractures, although they're quite rare in children, and you'll do the same sort of assessments of saturation, respiratory rate, and functionality there as well. Circulation wise, again, you're going to do a circulatory assessment. What are you going to do? You're going to do the same things. Take a pulse, take a pressure. The numbers will be different. And we all have little aid memoirs. Again, we'll talk about in a second about what's normal for each particular age. But essentially, it's the same, isn't it? You're taking a pulse, you're doing a blood pressure, you'll do a capillary refill. You'll get a sense of whether they've got good peripheral perfusion by looking at warmth and whether they're moving and etc. And it's nothing different there. And then the H, looking at heads. Now, we will spend a little bit of time talking about heads, because in trauma in children, in terms of major trauma, the vast majority of them are actually isolated head injuries. So in pediatrics, the big group of patients who end up with significant mortality and morbidity from trauma are head injuries. And in particular, head injuries in the very young. And sadly, quite a few of those might actually be related to non-accidental injury. But heads, we're also going to look at the spine, and we're going to look at other aspects of the patient. So this is going into your secondary survey. So also the question about when do you consider a child a child? And this is a strange one. But the way I think about it, and the way a lot of my colleagues think about it, and the way a lot of the rest of the world thinks about it, interestingly, is like this. So you have these sort of different brilliance in life. Once you get to about the age 12, you can pretty much consider your patients to be behaving, well, actually, definitely behaving physiologically and to a large extent pathologically as an adult. So over the age of 12, generally speaking, most of us would be relatively comfortable from the physiological and pathological perspective. However, the emotional side, the management of the families, and all of those kind of things clearly will be different. But, put those to one side. We're dealing with our major trauma patient who's got a life-threatening potential injury. We can do the same sort of things at age 12. And generally speaking, they're big enough that you and I would probably be fairly confident about getting things like intravenous access. We're going to be using the same sort of face mask. We'll be using the same sort of BVMs. We'll be doing the same kind of thing, just a little bit smaller. Although, quite frankly, some of the size of some of the 12-year-olds are actually better than me, to be honest. There is a difference in the lower age groups. So in the neonates, in the under 3 months, in under 1-year-olds, in the newborns, and certainly newborns I consider to be only vaguely human, to be honest. Their physiology is so different from adults that they're a whole different group. But in that very young group who are quite difficult, that's a group who, from a trauma perspective, are the ones who essentially, they're usually just isolated head injuries from somebody who's been dropped down the stairs, accidentally dropped, or they're non-accidental where they have multiple injuries, but not necessarily all in one go. They're quite a complex group. But there is this sort of spectrum. And at some point along this spectrum, you're going to become more and more confident and competent and comfortable about what you can do with that group of patients. And for most of us, age 12, not a problem. And certainly going down to age 8 and 6, you can still use your skills relatively comfortably as you would in an adult. I've laboured that point enough. Well, let's go on and have a think about what we're going to do. So does difference? What is the difference between adults and kids when we're talking about resuscitation and major trauma? Well, clearly they're a different size. And because they're a different size, you're going to have to adapt a little bit of the kit that you use. You can't take a normal adult size OPA and just shove it into a kid, but you know how to measure these sort of things. The measurement is the same. You're still going to go from the center of the teeth to the angle of the jaw and measure that and test it and work with it in the same way that you would do in an adult. There might be slight variations in technique when you're using different bits of kit. So you might be using a different ET blade when you're intubating the patient because you're lifting up the epiglottis, but that's not something we're going to teach you tonight. These are the sort of things that you will have done in your training. We'll talk about training at the end. So they're a different size and they are a different weight. So you have to do a lot of your calculations based on the patient's size, really the weight, size, weight, same sort of thing. And you have to do calculations. But actually, there's a lot of help out there to help you with those calculations, and don't make mistakes and don't guess. And we do need a range of different kits, which is out there. And there's a little bit of variation in terms of shape, actually. If we just whiz back a slide, you can see the classic one that we always talk about, isn't it? Is the difference in the size of the head and the shape of the head. Quite a good example here that if you look at the little baby down the bottom there, you can see that the occiput's poking out the back. So a neutral position in the child requires a pad behind the shoulders, whereas in an adult, for somebody of my age, they need a pad behind the neck because they're getting old and falling apart. These are not things which you should be unfamiliar with. These are things which we're taught in our training, and we're taught as we go along. How we put them together and how we do them is a bit more complicated. So yeah, what are the things that are going to challenge us? The airway, we've talked about, slightly different sized kit that we're going to use in that child, sizing them in different ways, and we've got cognitive aids. We've got IV access, which is more challenging in children, certainly getting intravenous access, but we know there's a solution to that. I know you're thinking about it already. We'll talk about it in a sec. Positioning up there on the top right, again, we talked about this neutral position, so getting the face basically flat to the bed. And, it's not, a 2-year-old needs a pad behind the shoulders and a 6-year-old needs nothing, and a 12-year-old needs a pad behind the head. You have a child in front of you, look at what surface they're on, and you adjust it to be the best position you can with the head and the face pointing towards the ceiling in neutral position. Managing the chest, so getting intrathoracic access in terms of putting limbs in, it's no real different. In fact, it's easier in children. The big problem we have in adults, isn't it, that actually you can't get into the chest because they're too fat. Sorry about that. That's the case that we are here. And airways, actually, one of the interesting things I found dealing with pediatric airways is they're actually easier than dealing with adult airways. Adults have things like wobbly teeth. Teeth, to some extent. They've got dentures, they've got osteoarthritis of the jaw, they've got terrible sort of, they've got tumors in the back of the throat, they've got all sorts of things which can make your life horrible and go wrong. They're also big, and they're quite difficult to manage with a laryngoscope or getting an eye gel and things like that. Children, they're really mobile and they're quite small, and you're stronger than they are. So actually intubating a child is actually arguably a much easier thing to do in terms of the physicality than intubating an adult. And so we need to think about these sort of things. There's quite a lot of challenges that I've talked about there about the difference, but actually fundamentally it's the same. And in many respects, it could actually be easier. And then down there, we've got to think about fluids, about which blood are we going to give, and we'll talk about transfusion strategies shortly. But essentially, they're the same. We like to give blood and blood products to children who are bleeding, and we like to give TXA to them. And we give a different use of TXA because they're smaller, which is the whole thing we were talking about in terms of size before. Now, things that we've been talking about is the idea that we have to make some adjustments. So we're doing the same but different, same but different. So I'm going to give TXA, but it's going to be a different dose. I'm going to put an airway in, but it's going to be a different size. I'm going to give some fluids, but it's a different amount. I'm going to give some paracetamol, but it's a different amount. How do I do that? And I'll tell you now, I've worked in pediatric emergency medicine for, gosh, a very, very long time, decades, quite frankly. And pretty much the only drug which I will not look up in terms of the dosage is paracetamol, because I prescribe it every day. I prescribe antibiotics pretty much every day as well. And I'll still go back to the BNF and I will look it up. because it's really easy to make mistakes in terms of size in children when you're trying to do the calculations in your head. And we know that we can do this better. So things that we can think about. Well, you may have seen this. This is the wet flag approach that we use on the APLS courses about the general things that we need to do in the emergency situation. So how do you calculate a weight? You know, how many joules are you going to use if you're doing defibrillations? What tube size are you going to use for a child? What fluid, what adrenaline, and what glucose? Now, I could probably ask you now, if you want, I won't ask you to do it now, but I could probably put in the webinar chat, show me the formula for doing a tube size. And you go, oh, okay, fine, yeah, I can do it. It's h over 4 + 4. Fine, brilliant, awesome. Doing that at the roadside, when there's noise, when there's stress, when there's a family there, even doing very simple calculations, very, very simple calculations is just a nightmare. So don't do it, is my basic argument. Use an app or use something else. You'll also be familiar with this one, which is the weight-based calculations. This is from APLS. If anybody here can remember this in the heat of battle or the heat of a proper going recitation, then, you know, chapeau, you have my hat to you. I can't, and I've got it written on the wall in recess. I can't remember this sort of stuff, and I certainly can't do calculations when I'm there. There are alternative methods. This is the one that we talk about on APLS. It's wrong on ATTACK, which is the two finger method. So age 1, 3, 5, 7, 9 relates to 10, 15, 20, 25, 30. So if you really want to do things and remember things with your hands, you can. But actually in this day and age, and as who was it, Janice, this sort of about JR Calc, absolutely. You know, there are apps which are available here. These are some of the ones which I and some of my colleagues use. You know, the BNF for children. PTD's got some great guidelines on there. Mersey Burns is a fantastic app calculating Mersey Burns, which if you've not used it, download it, please. Well, it's a bit difficult to find at the moment. Couldn't find it the other day. But also, absolutely, as you talked about, aid memoirs. So either in paper format or in electronic format. So on the right-hand side, the JR Calc thing, we've got the page for age, which is excellent. Really, really good under difficult circumstances to use. No shame ever in using a cognitive aid like this. And on the left, it's the 4-year-old RSI card from Sydney Hems. For Northwest Air Ambulance, we have something very, very similar. It's a little bit more detailed. There's a few more drugs on, including things like ventilator settings. But on the way to a job, on the way to a child which you think might be poorly injured, you know, you get these things out on the way, don't you? You have a chat, you have a conversation with your colleague. Say, what are we looking at? How are we going to organize our kit? What are we looking for? And of course, the other thing, which I'm sure all of the people here will have experienced, is you get sent to a 2-year-old and actually you walk through the door and they find they're 8. So having the ability to sort of flip between one and the other, which, you know, these systems do have, is very good. The bottom line is, please don't use your brain. You will make a mistake. Some years ago, and I'm quite happy to tell you this, I was dealing with a child who was 1 year old, and they had a new onset DKA, and the dose for insulin in a child of that age with onset DKA is 0.1 milligrams per kilogram per hour. And at 1 year old, they weighed 10 kilos and the dose was 0.1. So it was like trying to calculate binary. Everything was a 0 and a 1. And we managed to prescribe 10 times a dose of insulin, which was not a good thing to do. Fortunately, no harm came to the patient because one of my nursing colleagues had a look at it and went, "You two are idiots. What are you doing?" But it was so close to trying to make a mistake by doing things in my head. Now we have things like aid memoirs. We have the pediatric calculator that we use on the spreadsheet, can't remember its name now. We use MD, and that tells you, the 1 year old, this is what you're going to put in the syringe and this is going to how to work it. I stress the point too much, but I can't stress it enough. It will save you a lot of pain if you use an aid memoir. But let's take a slightly different move. And Andrew, I've got to stop at this point. So I've sort of pitched my thesis here, haven't I, that actually that kids are little adults and there's an awful lot we can do. Has anything cropped up in your mind, anything cropped up on the Q&A yet that we need to sort of address?
Nothing in the questions and answers, Simon. Lots of comments and suggestions in the chat, but nobody's using the Q&A box yet.
Okay, well, if anybody pops those in, we'll stop periodically and have a think about them as we go along. Fine, let's have a little think about more about the pathology of children and why they are a little bit different. One of the things is they're different in terms of size. And one of the things that my paramedic colleagues or my pre-hospital colleagues are very good at is looking at the scene and trying to work out what's gone on. And if you see something like this, there's clearly what looks like to be a head impact into the windscreen. If you're going up to a slightly higher level, you'll be noticing how close it is to the A pillar, whether or not that's something which looks like it's been a direct impact, how close it is, which part of the windscreen it is. And that's probably not a bad place to put your head into. But in modern cars, they're relatively well designed to sort of absorb an impact at this point. Certainly wouldn't be a little bit over close to that pillar, would you? Where there'd be less sort of things going back. You're good at this sort of stuff. And it's really helpful to us in the emergency department when you come in to give us as much information as possible about what looks to have happened and what the vehicle, if it's an RTC, or what the height, or what's on the ground, or whatever has happened to the child. And you'll be familiar with this kind of thing. I'm sure you've seen it in textbooks about the typical injuries when a child is hit by a car, which is a very common cause of trauma in the slightly older group. I said that the youngsters, the real young ones, are the head injuries. A bit older, little Johnny, he's out at 7 o'clock at night, runs across, 7 years old, runs across the road and gets hit by a car. You see this sort of thing. So an initial impact there on the bumper at the knee, so giving them a femoral fracture or a knee fracture. The chest impacting onto the front part of the bonnet, the head then down onto the bonnet, potentially sliding up onto the windscreen, and then a third impact when they get, I think it's probably best if we give you an idea about what this looks like in practice. So let's see if this one works. I do apologize for using anything from the Daily Mail. Now, I have to tell you at this point, this child was actually uninjured, believe it or not. Well, they had some injuries, but they were pretty minor injuries. But look at what happens here at the point of impact. So knees, chest, head, and then that's third impact as they go down the road. And as I must stress, this child was not actually severely injured, which is another paradox that we see in children. They're very bouncy. So they're much more mobile. They're much more mobile. They're much more flexible than adults. And we do see quite remarkable things. Again, I saw a child who mum was doing the washing up in a 3-story townhouse, believe it or not. So she's doing that, and then all of a sudden she just saw a child fall from a 2nd floor window into the garden. This guy actually just drove off. Nice bloke, wasn't he? And that child was actually fine, unbelievably. But kids are really difficult in this respect, because you'll see one child like the one we've just seen now, who has what looks like a tremendously awful mechanism of injury, gets up and walks away. And you'll see another child with a very similar past injury who actually then subsequently has significant problems. And there are a few things that we look out for. One of which is this one I'll talk about in a second, but anybody who, you've looked at this kid, you've been sent out to see them, they've had some abdominal pain, and you arrive and see this. There are some things which should be going through your head already. We'll come back to that in a minute. And you'll be familiar with this sort of thing, where you see, this is a classic lap belt injury. Interesting, it's a lap belt, not a 3-point or a 4-point harness, because that's what sometimes they do for the kids, because obviously kids are bouncing, they don't need to be restrained. This is not true, they do. Now, this is interesting, actually. So this is a sort of child, I think I took this off the internet, but this would be a typical child that I might quite happily see in the emergency department with almost no signs. So you'd see this on the skin. They'd be a bit sore. They would have no cardiovascular problems. They'd be absolutely fine. And yet they could have some very significant pathology, which is not yet physiologically apparent. And that's one of the things you've got to be quite careful with kids. That's why you've got to be careful with everybody, but it's more so in children than I think in adults, that they don't seem to show the initial pathologies, and they see different patterns of injury. If you saw this sort of thing in an adult, a big seatbelt sign, you're thinking of fractured sternum, some fractured ribs, maybe a liver or a splenic injury. In a child, because of the abdominal organs are, they're much more further down in the abdomen, and the thinner, and the promontory over where the lumbar spine is, and where I'll show you a CT in a second, you get different patterns of injury. And again, to reiterate, because it's really important, that might not be hugely apparent, but reading the scene, having a look at this, of a child who's come off a bike and has landed on the handlebar, you sold me a CT at that point. That is the story I want to know. That's all I need to know. We're going for a CT, and I'll explain why in a sec. So yeah, Clinical approach. What do we talk about? We talked about the different elements of March. Let's just dig into that a little bit more before we go back to injury patterns. So things that we can do in children for these 5 elements that might be slightly different. Number 1, massive hemorrhage. Well, what do we do in adults? Well, we put on pelvic binders, we put on splints, we use things like Celox or other gauzes to procoagulant dressings and things. We can put on a tourniquet and we give tranexamic acid. It's difficult in children to do a number of these things. I mean, certainly that pelvic binder on there is to a degree holding something in fashion, but it's not functioning the same way as an adult does. But some immobilization of the pelvis with whatever device you can use. And this is the sort of thing you should be going away from this webinar, going, hang on a minute, what have we got in the back of the ambulance that we could put on that would function as a pelvic binder? Has the pelvic binder that we in our service has actually provided us with, would it work? Would it fit? And is there an alternative? Would we have to do something with a sheet or something like that? You know, with the femoral splints that we got, can we just get them into a box splint, or would we actually try and put something in traction? Well, how is that going to work in my practice? Could I get a tourniquet uneducated? Will it actually close small enough to go around somebody with exsanguinating hemorrhage? What's our alternative? And actually, just, you know, in children, the blood pressure is not high. You can get away with other things that go on. Yeah, Michael O'Connor, I absolutely agree with your comment. Large vac splints, yes. Vac splints, yes. We'll talk about that in immobilization in a second. Airway stuff, again, I'm not going to reiterate too much of this. It's pretty much similar to adults. It's just a different sizing and slightly different positioning that we've talked about already. In the chest, decompression of things like tension pneumothoraces and hemothoraces, they do occur in children. They're probably not as common as they are in adults from the similar sort of levels of trauma. And a lot of this is due to the fact that the thoracic cage is very bouncy and it's very, very, very flexible. What we do see, interestingly, in children is those who have potentially quite serious pulmonary damage, so potentially pneumothorax, but often significant pulmonary contusions in the absence of any rib fractures, and often with relatively little on the outside. And again, that's when we're really looking at, are you guys to help us in terms of the mechanism of what's happened, the peripheral thing, what's the story of what happened that's going to lead us to an idea of what could be going on there. And as you probably know already, things like pulmonary contusions don't necessarily present straight away. They're things that can develop over the first 12, 24 hours. And again, the kids are out there trying to fool us about, you know, we're okay. Actually, we're not. We're just waiting to capture you in a few hours' time when we go off really badly. In terms of other procedures into the chest in our resuscitation process, so decompression, fine, doing things, thoracostomies for those of you who are CCPs, APs, and if that's in part of your practice, yes, there's no reason why you can't do them in children who's positively pressure ventilated. They're just technically more difficult because my finger is bigger than the rib space of a lot of children under the age of 6. You know, quite difficult to get. I might get my pink, but it's quite difficult to do. It's technically difficult, but the approach is the same. In terms of circulation, what are you going to do? It's tricky. We use resuscitation fluids, exactly the same approach. Our major hemorrhage approach to children is the same, except we're going to give 10 mils per kilo blood boluses as opposed to units. That's fine. We're still going to give yellow. So love FFP in kids, love packed red cells. This says whole blood here, which of course we don't have at the moment, although there's a trial about to start. So I think it's actually started, the SWIFT trial, looking at whole blood in major trauma patients, not including children. And that's an interesting point, is most trials don't include children. So a lot of the evidence that we talk about how to resuscitate a child is based on adult trials that we translate into kids. Who knows whether that's the right thing to do. Easy IOs, are all familiar with them. They are fantastic. One of the greatest things I ever learned from Rachel, one of the sisters at RMCH, who is absolutely brilliant, wonderful person. And we were doing a resuscitation and some years ago, and when IOs were really starting to come in, and it was one of those ones where people were really struggling to get access to a child. And Rachel, I think, basically said something along the lines of, okay, fine, so we're going to have 2 goes now to get this. And at that point, I'm either going to give you the IO gun or I'm going to put this IO into you, which kind of got me in the mood for, I think we're going to have 2 goes, because I, you know, at that point, use the IO. They're very, very good. They're really, really, oh dear, Ian employs withdrawn the small red IAZI needle. Use a bigger one and go in the humerus or the femur. And they're a really great bit of kit, and clearly struggling to get IV access can be one of those real HRM situations and CRM situations where everybody gets sucked into, I've got to get a Venflon, I've got to get a Venflon, I've got to get a Venflon, or intravenous cannula of your choice. But actually you just need to move on and do the IO, and it's not that bad. You know, I don't know what, you know, just put an IO in. If you need IV access, just get on and do it, would be my approach. Fine. Where do we go for? Circulation, but the approach is the same. Get access, give some fluids, don't give too many fluids. Hypotensive resuscitation in kids, that's a tricky one. We don't really know the answer to that one. And actually, when you look at the normal blood pressure range, you know, in a small child, the normal blood pressure is 80. So what are you shooting for if you're going for hypotensive? These are really interesting questions, but they're quite difficult. You're probably going to use different measures from blood pressure to determine how much fluids to give. And it will be things like what their conscious level is. Do they have a radial pulse? Have they got reasonable peripheral perfusion? It's complicated, but the principles are the same. And then on the ATAC approach, the H is around head injury, spinal injury, and other things. And this is worth making a little bit of a plea for, really. And often when you go out to see a kid with a head injury, and you know, they might have had a fairly significant injury, but we've also seen that, you know, one child will fall off the back of the sofa and have a fairly significant head injury, and you've got to do something about it, and then we end up having a subdural and neurosurgery. And another kid comes out of a second floor window and is fine. You know, it's not difficult, but generally speaking, when you arrive, they all pretty much look like this, don't they? Because they hate you. You know, the average 2-year-old hates you. And the approach is, even if you turn up in a nice big ambulance, or you turn up in a car, or you go and see them, most 2-year-olds, you're not their mum. They're in pain, they're having a bad day, and pretty much they hate you. And differentiating between this kid, who is basically just annoyed and doesn't like you, perfectly reasonably, quite frankly, versus a kid who's got a start of an irritable process of having a brain injury, is complex. And how do you get around that? How do we get around that? Because it is hard. And I spend quite a lot of time in the ED sometimes just standing there and watching what's going on, giving myself 5 minutes. And, you know, it's easier in the ED, but even pre-hospitally, when you're trying to get things ready, you might just sort of stop and think, I'm just going to watch and get a feel for what's going on here. Is this normal irritable behavior, or is this abnormal irritable behavior? And that varies with the child, the circumstances, the age. Very difficult to do, but getting an impression about where you go. And I'm going to show you a video in a second, which I don't want you to laugh at or anything like that, because we don't laugh at other practitioners, although some of the practice on here I personally wouldn't do. But what I want you to do when I show you this video is I want you to look at the behavior of the child, and I want you to think in your own head about whether this is a child who is cerebrally irritated, whether they're very, very annoyed, or whether they're in pain, or whether they're in a combo of all three. Okay, so there isn't a right answer, by the way, but I still want you to think about it. Okay, so let's go on to here. I need to shoot this one through to a minute. Okay, so it's from a US TV show. Let's see if we can make this happen. Let's go. So this kid's fallen over from his own height and basically smacked the back of his head.
Highly combative. Typical of some a good amount of trauma. Oh my God. Oh my God. I'm gonna neighbor with the fire, okay? You fell and knocked yourself out, brother. Okay, so you relax. When they see your eyes. Bigger than the other. Usually signifies they're
okay, folks. So what did you think there? So I mean, you can chuck it in the chat. What was your feeling about looking at this sort of chart? It's not an uncommon situation when you get to these kids. So pop a few thoughts in there if you would, and I'll give you my thoughts based on a lot of experience of looking after these. I couldn't see it. Oh, sorry, Paula. Is he posturing decerebrate? No. Cooks possibly. Couldn't really hear the kids' reactions. Yeah, it's not brilliantly doing, but I thought there's enough going on there that we can have an idea. Agitated, scared, and overwhelmed. Yeah, cerebral due to movement of limbs. I can get off me 2 or 3, but he's terrified. Yeah, I think what I'm getting across here is, in that situation, the one that we saw there is a little bit difficult for help, but there's an awful lot going on there. So he's had a brain injury. He's been knocked out for a bit. He's then woken up, started to wake up, possibly a little bit confused, and then he's surrounded by people he doesn't know before who've strapped him to a stretcher and are sticking needles in him. And I don't think it's entirely inappropriate for him to be slightly annoyed. He's also probably in pain. And again, what I would do with this sort of child, and we see it not uncommonly, is actually say, well, actually, okay, guys, looking at this, and if you show the video further on, he's pretty much clearing his C-spine quite happily, thank you very much. And the mechanism isn't particularly worrying me about him having an unstable cervical spine injury. I'd probably be taking some of that things off, be trying to de-escalate the situation, having a bit of time to see what's going on, and thinking about things like analgesia. So head injuries hurt. And I know we're told all the time, aren't we, that things like opiates are not good for headaches. Well, they're not good for if you've got a migraine. But if you've been battered over the head and you've got a big bruise and a skull fracture, yeah, absolutely give them some opiates, absolutely give them some decent painkiller, and actually de-emphasize the environment. I went to a case with the air ambulance, and just to sort of, and we went to a difficult scene, hit by a car, very much like that I showed you before. And the child was irritable, really annoyed. They were difficult to control. There were family there. It was a complex environment. And what we decided is basically what we're going to do with this kid is we are going to put them in the back of the ambulance. This is not a safe environment. There's an ambulance station just down the road. So we're going to go down there. We're going to set up. We're going to RSI this kid and take him into RMCH. Fine. That is the plan. But while we're doing that, the child is okay. They've got an airway, they're irritable. We got access and we gave them some analgesia. And so what actually happened is that by the time we got to the ambulance station, which was just 5 minutes down the road, and we were just setting up for the RSI kit dump, actually, the child stopped being irritable. They stopped being annoyed. They had a parent with them. The analgesia was starting to work on this kid, and actually they settled down. And what I'm saying is that this balance of head injuries is really focusing on the whole picture of the kid. What is the environment? What's the psychological impact here? What am I doing? This is terrifying. Crikey, I'd be scared witless if I were, I've had these 4 blokes holding me down, sticking needles in me. That's not a rational conversation I'm going to be able to have with a 12-year-old. Incidentally, this kid did absolutely fine and didn't have any major injuries. There you go. Fine. Okay. Labor the point. But it is your biggest group of major trauma patients in children. It's the most complex one to deal with, but actually using your skills, a little bit of time and observation, some analgesia and some psychological support, and a little bit of hands-off perhaps is really good with this group of patients. If they're a little bit more obtunded, I think, was it Louise? I can't remember who said earlier on, sort of cocooning children. So the smaller children love to be swaddled. So you can use things like vacuum mattresses if we use them in ED, but the little PD boards and stuff like that, actually pop a smaller kid on those and wrap them up nice and tight and put a blanket around them. They will settle in that position. Older child like this, they don't like being swaddled. They don't like anything at this age, but there you go. So you're blending what you're going to do. You make sensible decisions, speak to your crew, speak to your partner, and speak to, get some advice and have a think about those sort of things. There you go. Right. Labor the point, but you get what I mean. This is not simple, but you have the skills. Fine. What else can we do in terms of kids? So what we're going to try and do is make them happy and not sad. So, if you terrify the kid, it's going to make your life a lot worse. And as I said, all 2-year-olds hate you. Nothing else you can do. Some other things that you might have seen knocking around, and we're increasingly using in the pre-hospital arena around enhanced pre-hospital care and in your adult emergency departments, is the use of things like ultrasound, because everybody loves a new toy, don't they? Everybody loves giving an ultrasound out there and doing things. In adults, it does have a role. In children, it probably doesn't have anywhere near as good a role. It's okay for things like the chest. So you can see pneumothoraces, you can see hemothoraces, you can have a look at the heart and see if somebody, if unfortunately you see a child with a penetrating injury, you can look for things like pericardial tamponades and stuff like that. That's absolutely fine. But this is a pericardial tamponade in the chest. But ultrasound in children has a very poor sensitivity because the type of injuries that they get are often related to the pancreas, or they're related to small bowel, or they're related to things like the kidneys and the retroperitoneum, and they don't bleed into the peritoneum. And what we're doing a lot with the ultrasound in the abdomen is looking for free fluid in the abdomen. And so the recommendation now, don't rely on ultrasound of the abdomen as a real diagnostic tool, which is a difference to what you'll see in adults. But the chest, yeah, and particularly in stabbings, yeah, okay, I'll give it a whirl. Fine, so a bit of ultrasound. The point I was going to try to make is that for a lot of these things in children, it is a wolf in sheep's clothing. It looks okay, but actually things are going wrong. So we've already talked about handlebars. I talk about it because actually it's one of the commonest causes for a child to require a trauma laparotomy is a handlebar problem. So landing on a handlebar like this causes major problems. And what it does is it looks like this. I'm not going to show that one. Here we've got a CT scan, and what I'm going to see here is the big bob in the middle is the spine, and over the foot of that you've got the pancreas, you've got the jejunum, and this is a jejunal perforation. This black stuff at the top is a perforated bowel with this kind of thing that we saw before. So those are the major things we're talking about, sort of assessment and initial management. I'm going to tell you a little bit now about what happens when the kids get to ED and the Children's Hospital and the Major Trauma Centre. Because, interestingly and differently to adults, increasingly, even if you've got sort of significant abdominal bleeding, so a liver laceration, a splenic rupture, something that looks like this is a spleen that's been taken out, absolutely terrible, loads of blood in the abdomen, we do not operate on kids. They seem to do absolutely fine by just giving them persistent blood products and coagulation products, and they settle down. Even something like this, the black bit in the liver here that goes across the middle, that is a severe intra-abdominal, intrahepatic rupture and bleed. We would treat this conservatively. In an act, we'd be going to theatre and packing it, or going down the line of doing interventional radiology. Magic, get into an artery, go up into the sort of small vessels, and then you can actually inject small amounts of, I've got a picture of it here actually, got a small amounts of gel or a little bit of beads that actually stop the bleeding. So if you look at this, you look down the bottom left as you look at it, can you see how there's just a little bit of, there's a little bit of a blush there? That's active bleeding from the hepatic vessel. And what we can do now in the older children, increasingly in children, is go in from an interventional point of view and actually just block those vessels off, and no need for surgery, because we really don't want to do big operations on children whilst they're growing unless we have to. And it's interesting that now a lot of the techniques that we've done this in children, we're now doing in adults. We very rarely operate on the liver and spleen and kidneys in adults. We can get away with interventional radiology. A couple of other things, anything else? I haven't mentioned it so far, but always think about non-accidental injury, not just in this age group, but particularly in the babies. The incidence of severe non-accidental injury in any child who's got major trauma, we will automatically look at it as if it's a potential for a non-accidental injury. Often it isn't, but many times, sadly, it is. So any information you can get at scene to help us with that sort of questioning and ideas, or what, even just you've got a gut feeling for whether things are right or wrong, please share that with us as we come in. And then we've got to think about where we go. Problem there. Major trauma centres for children are rare. Most children will end up in their trauma units. So paradox, it's rare. They don't get taken to major trauma centres, and the people who you receive handing over to may not be that comfortable with it in themselves. So we now have better support systems for getting out to the children and getting good quality support to the trauma units. And that's what we encourage our local networks to do. What is it all about? It's all about getting from the scene to the scanner for the diagnostics. CT is the answer for children, and then either interventional radiology or surgery. Two things to say. What can we do? I hope what I've suggested to you so far is that you have the skills. You know what an airway is, you know what respiration is, you know how to manage circulation, you know how to test head injuries. This is just an adaptation of the great skills you've got already. But it won't come naturally unless you test and you train and you just use, go and do this, go and get mannequins out, have a mess with it. But actually the best simulator you've got is your brain. So you go out to the next job. So maybe a pedestrian 24-year-old who's been knocked over by a car. When you reflect and thinking about it, say, well, okay, well, what would I do if that was a 4-year-old? How would my approach be different? Where would my kit be? How would I go? Where would I be going with this kit? Who would I get advice from? And just use that mental simulator to constantly train yourselves and think about things. So when it comes for real, you'll realize that actually, when we're looking at children, we're not really this idea, comparing apples and oranges, and people say they're actually completely different things. They're not. There's even a study There's a BMJ study that compared apples and oranges. And I think this is a little bit like comparing children and adults. Like, yeah, you can probably find some factors which are slightly different. You know, they are a slightly different color. One of them's got C's, the other one doesn't, and they are statistically significant differences. But you know what? Pretty much everything else is the same. And you have the kind of skills that you need to manage that group of patients, to manage adults, to manage older adults, to manage pregnant women, to manage all the sort of things that we go out to. And that's the beauty of the job that we do. The variation, the variability, and the wide skill set that we can apply across a whole range. And that, my friends, was my message for today.